The Residency Match Insiders. Today, let's try to do an H&P note that is complete for your rotations or observerships and try to impress your attendings. Okay, so let's play this. All right, ready? Let's go. So the H&P parts, you know them. The chief complaint, it has to be on the patient's words. The HPI, I like you to use these beginning statements. This is an 48-year-old male patient with past medical history of XYZ, and to add the OPQRST questions and 3 extra questions for possible differentials. What is in red, some attendants like to add it and have it from the beginning, and some attendants don't. Why? Because by giving this information, you are basically giving out the diagnosis. So some attendants like to leave this to the very end, so the other residents that are attending or paying attention to your presentation can try to figure it out. The review system the same, nothing has changed on that. Just keep in mind that and add the geriatric review system and history for patients 65 or older and the code status question. Don't forget to get the code status. Physical exam, labs, we like to use the fishbone diagram to report labs, meaning that those are the most important lab results. And assessment plan, what's going to kill the patient right there goes first. And let's go. So the review system, if you can type this 14-point review system, do it. But you are going to be a big nerd if you do that. Or you can just use one of the shortcuts like the ones I have in red. 14-point review system was done and it's negative except for what's mentioned in HPI. Or if the patient is nonverbal, unable to obtain due to current condition. But yes, ideally you have to go through a review system. And past medical history, give me more detail. If you're going to say that the patient has hypertension, you say it is currently controlled or not controlled, currently on these medications, had an echocardiogram most recently, if there is CAD, when did he have his last heart catheterization, his last TEE, TTE, and if there's any symptoms following a CVA, mention it there. Okay, so for the geriatric review system and history, this is basically a revision of what is very commonly happening on the geriatric population, like urinary incontinence, recent falls, memory loss. Please use validated questionnaires. For mental or memory loss, use the mini mental scale, and for depression, use the PHQ-9. Attendings love to have that information at hand. And baseline function, able to ambulate or not, using devices, dentures, glasses, ADLs or ADLs if the patient is independent doing them or if he needs assistance. Code status. So let's try to group this in 4 different groups. The patient can be DNR, DNI. Within DNR, DNI, he can choose to have selective treatment like just antibiotics, maybe vasopressor support, but no intubation or resuscitation. Or he can say, no, do not resuscitate me or intubate me, and also, I don't want your antibiotics, just keep me comfortable. I don't want to be in pain, I don't want to be short of breath, let me pass in a comfortable way. Dnr Post Intubation means that, let's say this patient was intubated emergently in the emergency department. Then after that, the family comes and says, oh, you know what, he's in bad shape. From now on, if he arrests, don't bring him back, don't resuscitate him. Full code, the patient wants everything done to save his life. And when reporting this, mention that it was discussed with the patient or the power of attorney. And if you can, fill out a POLS form to make it legal. Ideal physical exam has all these systems revised, and I'm saying systems because it's not an organ what is revised, it's the system. So it's the cardiovascular, it's not the heart, it's respiratory, it's not the lungs. And when giving away the vitals to the attendings, give range for all of them. So heart rate, it was from 60 to 80, respiratory rate from 18 to 25, give ranges. T max of 38.5, something like that. Okay, this is just for documentation. Why? Because for documentation we are we were supposed to do this amount of documentation. We cannot do just 3 or 4 organs or systems. We have to do at least 10. So keep that in mind. But when presenting, just present the pertinent ones, and you can say the rest of the physical exam is within normal limits. Labs, we like the fish diagram. Why? Because those are the most important lab results. You can start by mentioning the abnormal ones, and then you could just say the rest of the lab results are normal or within normal limits. And if someone is going to ask you about any of these labs, they're probably going to ask you to one of these, not something obscure like, oh, what's the calcium level. So on the fish diagram, we have the Chem7 in the left and the CBC on the right. The Chem7 is also known as the BMP, or basic metabolic profile, and the Chem12 is known as the CMP, or complete metabolic profile, and includes liver enzymes, bilirubin, calcium, albumin. Other testing to know and to look for is lactic acid as a sign of hypoperfusion or a marker for sepsis, procalcitonin as a way to differentiate if a respiratory infection is bacterial or viral, the dimer to rule out pulmonary embolism, urinalysis, ESR, CRP as early inflammatory markers, and cortisol as part of the septic panel. Imaging and EKG, when reporting them, please just report the pertinent findings. Don't try to read the whole report. Remember that this presentation to your attending should be done in less than 5 minutes, and don't forget to, from time to time, while presenting, asking the audience if they have more questions. During this presentation of the HPI, family history, social history, physical exam, do not give any explanation for your findings. This is just a reporting part of the H&P. You are just presenting the facts, and then you're coming to the assessment and plan part where you're going to give your best to shine. So first, let's start with a little summary of who is your patient, and then why he came to the hospital, and start listing his problems. So we're going through that. So the first problem is the one that is going to kill the patient, and the reason why we're keeping the patient here. The second, and all the other problems that come, are your abnormal findings, abnormal labs with explanations on medical terms. Do not say leukocytosis when it's in fact sepsis. Okay, keep moving. Mr. Marlborough is a 70-year-old male patient who presents to the ER with chief complaint of chest pain. Problem number one, what is going to kill this patient? The most dangerous problem, and the way I see is very effective for students, is to first list a differential diagnosis that you went through, making sure you rule out the most possible lethal threats. Next, if there's any more imaging or laboratory workup that you want to do for this patient, for this problem, list it after that. And then the treatment plan. And I start here with, where is this patient going to be admitted to based on your assessment? So where is this patient going to be admitted to? Observation versus inpatient. Basically, if you're going to send a patient to observation, it's because you're not sure that he has something that's going to keep him in the hospital for more than 2 days. And this can be the patient is ruling out for ACS, or ruling out for CVA, or syncope workup. Some exceptions to this rule are acute appendicitis, always observation; chest pain rule out, always observation; CVA rule out, always obs. For always inpatient, it's CHF exacerbation, always inpatient; COPD exacerbation, respiratory failure; CVA, confirmed CVA, always inpatient. So for observation, if the patient is going to stay, or you think he's going to stay only or less than 2 days, then it's observation. Med-surg versus tele. Med-surg patients do not need cardiac telemetry, whereas telemetry patients need cardiac monitoring, oxygen monitoring, and constant checking from nursing. So think about those patients that have a CVA, that have an NSTEMI, STEMI, CHF, CVA, to put them in telemetry, and the ones that are stable without any abnormal vital signs, no signs of sepsis, going to a medical surgical floor. Inpatient ICU for the patients that are very, very sick, in the verge of dying, need basal pressure support, have a big hemorrhagic bleed, need medication that need to be titrated or on a drip, like a nitroglycerin drip, levofed drip, things like that. Okay, then the list of problems that follow, you're going to list every problem, and all of them will need an etiology, an assessment of the current condition, and what is your plan for that patient, for that problem. Okay, and that's it. All right, so let's go to our sample case. So the ER calls you to evaluate Mr. Sang, who came with shortness of breath, and they are concerned for pneumonia because they found bilateral infiltrates on chest X-ray. So they call you for admission. So you go and see Mr. Sang. You said, okay, let's start with your OPQRST and add questions for pneumonia, CHF, pulmonary embolism, and NSTEMI as causes for shortness of breath. You got that, you got the family history, you got all the rest, and it starts looking like this. Mr. San is a 70-year-old male patient with past medical history of hypertension, previous MI in 2017, status scavenge, diastolic heart failure, who presents with shortness of breath for the last 7 days. Start with your PQRST. 7 days progressively worsening despite using albuterol inhaler at home. Described as severe, worse at night, associated to dry cough and bilateral lower extremity swelling. He denies any recent cough, subjective fever, or sick contacts. He denies any recent prolonged immobilization period of history of VT for pulmonary embolism. Denies any anginal chest pain. He reports having to use 3 pillows at nighttime to feel comfortable. The ER patient was found to have bilateral infiltrates in chest X-ray and was given a dose of Lasix and ceftriaxone IV. We were called for further workup. So you saw I went through questions for possible pneumonia, possible PE, and possible NSTEMI. And at the end I told what the ER did. Okay, social history, smokes, drinks, and uses marijuana. Code status Dnr denied, does not want to use vasopressor support if needed. Geriatric history, a little bit about him, and review system. I use a shortcut all the time, but if there's something pertinent, I will add it here or I will add it to the HPI. Like patient also report X, Y, and Z. Past medical history, I give the medications related to the chronic problems that the patient has. Okay, so his physical exam for vitals, as I said, give ranges. Heart rate, there's a range there. Respiratory rate, there's a range. O2 sat 84% on room air, 93% on 4 liters, and blood pressure ranges. Constitutional, he is on distress due to shortness of breath, cardiovascular, irregular heart rate, and tachycardic. Respiratory rate, decreased air passage, tachypneic, Cracos bilaterally, neurological, alert and oriented, and the rest of the physical exam within normal limits. Labs, white blood cell 9, hemoglobin 11, platelet 189, BNP, sodium 128, K 3.8, creatinine 1.8 from 1.0 2 months ago, and BUN of 20, 2 from 20 2 months ago. Procalcitonin is less than 0.05, BNP 1500 with a baseline BNP of 250 on discharge 2 months ago. The dimer is 150, troponin is 0.04 times 2. Chest X-ray with bilateral infiltrates and small pleural effusions. EKG, no ST changes, but patient was on AFib during the study. Last echo in 2/18/2021 with diastolic dysfunction and an ejection fraction of 50%. So assessment plan, if you are a third-year student, this will be expected from you, but you are about to become a resident and you should be able to do this whole explanation. I will leave that to you to read. But basically, any patient that has an O2 saturation of less than 88% is on acute hypoxic respiratory failure, and the source is this diastolic CHF exacerbation based on history, physical exam, BNP levels of 1500 in the setting of medication non-compliance, and probably dietary indiscretion. The patient drinks, smokes. So your differential diagnosis, you have to report that you went through an evaluation to rule out PE, and you think it's unlikely due to a negative D-dimer. You think it's unlikely pneumonia as the patient has a negative procalcitonin and absence of fever. You don't think it's NSTEMI due to stable troponin, so you would like to continue trending troponins and repeat an echocardiogram. You want to admit this patient to inpatient telemetry, continue oxygen supplementation, and start Lasix IV every 8 hours, and a little more things. Start on metoprolol, resume aspirin, whole ACE inhibitors due to renal failure, and you're saying that this patient may require cardiac consultation. Why I say may require cardiac consultation? Because unless you find the style of your attending, he may want you to deal with this on your own before you call cardiology. Unless you need a cardiac catheterization right now, then he might want you to be, taking care of this on your own. So the patient was on atrial fibrillation, the onset atrial fibrillation with RVR. A score that we like to use is the Chatzbas score, and it gives us the risk for clot formation and recommendations for anticoagulation. So for this patient, for now, we're going to do heparin drip until we finish his workup. And for mitral troponin elevation, likely type 2 demand ischemia in the setting of hypoxia. Rule out NSTEMI, so your differential diagnosis includes NSTEMI. You're going to continue training troponins, and plan depends on troponin levels and echo findings. I mean, if the troponins continue to elevate or the echo shows a sudden decrease in ejection fraction, then you might want to do a cardiac catheterization to find out what happened. Maybe this is an NSTEMI and not a type 2 demand ischemia. Hypervolemic hyponatremia due to volume depletion, likely due to CHF exacerbation. Repeat sodium levels, continual Lasix IV. Renal failure in the setting of volume depletion, it could be AKI or it could be ATN. You don't know right now, it depends on how the levels continue to trend. Bilateral small pleural effusions due to CHF exacerbation, continual Lasix IV, but you're listing everything. See, now once you finish listing all the abnormal findings on labs and history, you start with the chronic history. So you have CAD, the status post CABG, needs workup, continue training troponins, follow up echo. You don't know if this CHF exacerbation is a byproduct of just his lifestyle or he had another MI. Hypertension is stable, and then you go through, he smokes, right? So we're not going to say tobacco dependency, we say nicotine dependence and abuse because he's abusing it. Otherwise, he wouldn't be smoking. And this is chronic, and you offer a nicotine replacement therapy, maybe a patch or maybe a gum, and you provide counseling. Same with alcohol dependency, but alcohol dependency is different and special because it can end on seizure withdrawal syndrome. So for this patient, for alcohol users, we like to use the CWA score, and treatment for symptoms of withdrawal are based on this score. We provide counseling against alcohol use, same with marijuana, DVT prophylaxis at the end. Every patient will need DVT prophylaxis unless they are on anticoagulation at this time. So for this patient, he's on anticoagulation with heparin drip for atrial fibrillation. For GA prophylaxis, unless they are on high dose steroids or in the ICU, they don't require GA prophylaxis. But you have to notate that. Same with IV fluids, you have to report which is your choice for IV fluids. For this position, you have to say this patient, where is he going at the end? And at the end, what you foresee is going to be his discharge planning, home, nursing home, subacute level. And that's it for what I think will be the ideal H&P. Good luck. Tour on how my EHR looks. This is for Citrix Cerner Millennium, and this is the interface. It's very friendly. It gives you the patient's name here. This is a test patient, so you will see the solution test is the patient's name. It gives you date of birth, age, all up here. Code status, very important up here in case you have to quickly check the chart. So for a patient to be admitted, you have to go to provider view, look for two orders. One is the PSO order, and then go to this little market here and sign and say, okay, this patient is going to get admitted. So let's put some initial orders. So I want this patient to go to inpatient. So you choose this, a lot of clicking. So you say attending physician is going to be Jonathan Munoz. Reason for admission is going to be CHF exacerbation. Level of care, we're going to do telemetry. Service line, we're going to do telemetry. Expected length of stay, it's a must to check on this. So sign. That's it. The patient has orders for admission. Now we need to give orders for treatment. So the same, look for the admission, medicine, telemetry orders, go to the marketplace, sign, and get ready to prepare the basics of the admission order. So this chart will have only the basics. So we need a full code status. For this patient, he said he wants to be DNR. And for vital signs, we're going to do the same standards of care per unit. So it's already selected. And for DVT prophylaxis, let's say we want to do Lovenox 30. I know for the other patient we said complete anticoagulation. For this is just an example. Activity as tolerated, and diet, we want him on MPO. Let's say he has to be MPO for a cardiac catheterization. So IV fluids, we want IV fluids, so check IV fluids. Maybe I want him on sodium chloride at 75 per hour. Then you have to return to the previous window, Sofran, and you want him on a sleeping pill in case he cannot sleep at night. For labs for the morning, we want a CBC and a BMP and magnesium levels and lactic acid. And then for we want the patient to be we want a consult with the physician. So you check all this, you check or initiate now, and it's going to ask you more questions about these things. So the ones that have an X, these still have pending questions. So for the code status DNR, such an important decision. So did you discuss it with the patient, with the legal decision maker? There's a pulse form available, so I discussed it with the patient. And type of treatment, he doesn't want to be intubated. Okay, perfect. So look for another one that has an X, that means pending. Nothing else. Everything else. Oh, there's one more here, the consult to physician. So we want a physician to consult in this case. So I guess you can just type here, for example, one of the cardiologists who works here is Dr. Bangala. So Bangala comes up. I want him to see chest exacerbation consult. Of course, you have to call Dr. Bangala on his phone and say, hey, I have this patient that presents with CHF. Could you see him? And then he'll give you ideas. So after that, you just sign what is pending here. Reason for consult, CHF. Okay, sign. It's going to give you repeat orders if there's one. So since for this patient there's already these orders, so if you want to keep them, you keep them. If not, yeah. So at the end, signed, and the orders are there. Now you want more orders because we said we want this patient to be on Lasix IV, and we didn't see the orders for Lasix there, right? So you just go and add more orders. So you want IV Lasix, then you want an echocardiogram. You have to look for it. Complete, and then you also want troponins, zero troponins. Is gonna this icon here means this is a power chart, so you have to still go and modify more things in there. And you want this patient to be on aspirin, so you look for an aspirin, and you want this patient to be on metoprolol, so you have to add those things. Metoprolol, I don't know, 25 PAD. So done. And you check your orders. Is any of these one has pending thing? No. Order for signature. Yeah, the echocardiogram has one, so it's gonna ask you. Okay, so reason for the exam. Just choose one. And who you want to read this? I want Dr. Bangala. So look for his name. Black. Sign. If it's a repeat testing, it's going to give you this option to change. And now your patient is in and has orders for admissions. Now you have to do an H&P. So you'll go to documentation, click on add, and if it's one of your favorites, or you can scroll down this and maybe find the admission H&P note, click on OK, and start filling up all the available boxes. So H&P, no, history of present illness, chief complaint, history of present illness. You write down all what you need to write, including your geriatric review system, family history, social history, because you may not find every space for all the information that you have. So you just have to keep adding wherever you can. Make this note make sense. Review system, add your shortcut or your whole review system if you want. No one is going to blame you if you do one or the other. But if they ask you, you have to know. So physical exam, I like to do this ... and this means there is a smart phrase. So I like to choose my pre-selected physical exam and just go through it and say, oh no, he is comatose, he is obese, and respiratory, he is tachypnic, short of breath, wheezing, things like that for a physical exam. And then you keep scrolling down on the sides, it will populate the medications that you already ordered, the whole medications, and so assessment and plan. You can use a problem list that will auto-populate all these, or you can just, like I usually do, I delete all that and start from zero, from scratch, and I start saying acute hypoxic respiratory failure. And then due to CHF, and I copy all what we discussed first, right? Like this differential diagnosis, PE, and STEMI, pneumonia, likely not the reason, as there is negative, D-dimer, no fever, neck focal, workup, echo, trend troponins, plan, admit to telemetry, continue LASIX, and blah, and blah, and blah. Then continue listing your problems, problem number 2, blah, 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 problem number 3, blah, 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 and you know all what we did. And then sign and submit, H&P, sign, and that's it. Your patient submitted and has an H&P, your work is done.